Okay, hello everyone. Let's see, it's 5:08 according to my time. So I'll be aware if anybody else or when more persons start to arrive. And hopefully, but we can get started meanwhile. And I'm going to be the one moving the slides. So those of you that are speaking, Nahil, Yvette, and Billy, let me know when next, in case I don't get it. Okay. And yes, this is going to be recorded. It's being recorded now. And for those persons that aren't able to make it, also for you to be able to come back to it later and maybe review some sections of it as needed. So let's see. All right. And here we are. All right. And so I've written down somewhere, but not right in front of me. Who's going to be starting us off?
Lily.
Okay. Are you here, Lily? Let's see. Not yet. Right. Where's Lily? Let me see if they're going to start. As soon as Lily comes on, we'll be ready to get started. Since she's the first one here, she is. Okay. All right, so we're going to get started. And so, as I said, we're in recording mode. So you'll be able to come back to this later. And and those persons that aren't here will be able to get back to it, and we'll review it with them later as well. So trauma-informed care with Latinx communities, this is going to be a two-parter. We're doing the first part today. So we broke it down into these slides, and then we'll be doing a follow-up on our next one for next month. And so November, we'll be doing the second part. And the first person to start today will be Lily. And Lily, I have control of this, and you let me know when you need me to go on to the next slide, okay?
Perfect. Thank you so much.
And it's handed off to you.
Thank you. Let's start off with the first slide. Or next one.
Okay.
One more slide. There we go. So as we're talking about trauma-informed care, a trauma-informed approach, we'll go into a little bit about how people, in this case, two people may be exposed to the same event or series of events, but experience and interpret these events in vastly different ways. And as we continue talking, we'll discuss on how is it that happens, right? Next slide. So a definition of trauma, the Center for Health Care Strategies has this one. And as I looked through different definitions, I felt like this one was the most, was the one that best fit our way of working with trauma.
Okay.
Trauma is a pervasive problem and that results from exposure to an incident or series of events that are emotionally disturbing or life-threatening with lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and or spiritual well-being, right? And as we continue to talking a little bit about trauma, we'll see how these are taken into account on how do these either incidents or series of events happen, and how is it that they perturb us, right? Next slide. We also have generational trauma, and as defined previously, these incidents, right? We're looking at generational trauma, which is also known as either intergenerational, multi-generational, or transgenerational trauma. And this is defined as trauma that gets passed down from those who directly experience an incident to subsequent generations intergenerationally. That may begin with traumatic events affecting an individual, affecting multiple family members, or collective trauma affecting larger community, cultural, racial, ethnic, or other groups or populations, such as historical trauma, right? And these can be seen in our families as things that we've known have happened from one generation to the other, to the other, to the other. And sometimes so much so that we don't really yet have categorized them as trauma, but eventually we sort of kind of get into like the know of how that works into, how it works itself into trauma. And then there's the other part of epigenetics. And if anybody's familiar with the term epigenetics, it's basically that the genes retain some memory of the past experiences that obviously get passed down. And there's a lot of research behind how women, in the sense of when carrying a child, that they go through their own traumas, this child receives some of that trauma. And then there's also research that studies how males have been able to pass on traumas through their DNA as well, without being the ones to carry the child, but they still pass down trauma in the form of their DNA or their genes. Next slide. And then the other form of trauma, which I think is very near and dear to our hearts, as this is the work that we do, secondary or vicarious trauma is another form of trauma, which in this form, a person develops trauma symptoms from having been exposed to or have had close contact with someone who has experienced these traumatic events, such as family members, us, mental health professionals, and others who care for those who've experienced traumatic events and are at risk of vicarious trauma, and the symptoms often mirror those of PTSD. So as we treat our families, talk to our caregivers that are sharing with us how they themselves or their children, family members have experienced certain traumas, just keep in the back of your mind how this might also be affecting them, right? Sometimes people just share information so it feels like just generically or nonchalantly. But then when we dig in a little bit further and we ask them, how are they dealing with these events? How are they feeling about it? They basically tell you they're on automatic pilot and they're just trying to get their family member services, and not really putting themselves in the shoes of, wow, that traumatized me as well. So we'll talk a little bit more about that and what those symptoms reflect physiologically as well as emotionally and mentally. Next slide. So here I have a question for everybody, and please feel free to share. You can either unmute yourselves or in the chat. Who do we think were the first group identified? Who was the first group identified with intergenerational trauma? Does anybody have an idea? African Americans, the first group identified. Great, thank you, Charles. That is one of the groups, but one of the first groups where there has been like the research behind it. Refugees, another really good one. Thank you, Jaylene. Native Americans, another really good one. And the question becomes like where the study sort of came, immigrants, getting closer, right?
About
Anybody
Jews,
else?
Holocaust with the Jews.
Holocaust. A lot of our research comes from, a lot of the research in regards to intergenerational trauma, and books have been done, have been written and speak about how this in proportion speaks to how epigenetics really comes into play about how some of this trauma is veterans for sure. Thank you, Roxanne. Definitely, but definitely the Holocaust Jews are the first ones that we have identified in research of this intergenerational trauma. Thank you for that. Thank you, everybody that shared. Next slide.
I just guessed, by the way. So.
Did you?
Yeah,
Oh, I thought you were
that.
the answers. No.
I'm not that sophisticated on the internet. So.
Thank you. Next slide, Dr. Carnes.
Okay. What happened? Okay.
One more. So here we have some of the history and biopsychosocial issues that affect Latinx communities. Okay, and here's just a few. And as I'm reading through these, I want you to think of maybe what other ones haven't been identified here. So we have molestation, substance abuse, intimate partner violence or DV, extramarital affairs, spiritual and or religious, unspoken rules, stigma, assimilation, acculturation, racism, discrimination, loss of family members, either to those who remarried or remained in the country of origin, stayed back through death or murder, suicide, violence, physical abuse, rape, human trafficking, poor shelter, housing conditions, gang violence, to name a few, right? Historical biopsychosocial issues that are considered traumatic in the Latinx communities. So then my next question is also in the chat, any other issues that you've seen prevalent as traumatic in our communities that haven't either been mentioned here that you think might be just as traumatizing? Anybody else? The fear or threat of deportation. Thank you, Emily. 100%. Yes. Yes, the fear or the threat of deportation. Thank you, Emily, for that. Any other ones? Language barriers. Yes, right? Being afraid of not being able to have the language, the tools, the skills to be able to share what's on your mind to defend yourself and whatnot. Thank you. Thank you for that. Please continue adding if you feel there's any more onto that chat. Next slide, Dr. Carnes. So trauma here continued as we're sharing, although trauma can occur at any age, it is particularly debilitating and have long-term effects on children's developing brains, often referred to as the adverse childhood experiences or ACEs, as we're very well aware of as we do these screenings with all our clients. Exposure to these experiences is common across all sectors of society today. We'll go a little bit more about what these ACEs refer to, and just a brief overview as it's something that we continuously work on. Next slide. So we've seen this form. Everybody has seen our screener, right? And as we continue talking a little bit more, and Nahil and Yvette and Dr. Carnes will share, is how these experiences affect children adversely, psychologically, emotionally, physically, as we're thinking and putting ourselves in the shoes of being the assessors in these cases, how we can connect a couple of different points that, as they're sort of like spit out by parents and caregivers or clients, or sometimes people that are referring our children over to, or our clients over to, that sometimes it just looks like discombobulated pieces of this is what's going on. And maybe putting it in this order is one of our thoughts as an assessor, as a clinician, is to say, I wonder if this child has experienced any trauma, right? And being able to think of, and I know, Julie, you shared with me this the other day, there's a book that Dr. Bruce Perry and Oprah Winfrey put together called What Happened to You? And that comes from that thought of, in the past, we really came from this place of, say that again. Did somebody share something? No. That basically the thought in the past had always been, what's wrong with you, right? Like, this is how many of the assessments sort of happen. What happened to you, right? Well, what's wrong with you? Why are you like this? As opposed to what happened to you, is what I meant to say.
Yeah.
Thank you for that. Next slide, Dr. Fernandez. And here are some possible trauma symptoms that sometimes, as we see them separately, or maybe one or two, we don't automatically think possible trauma. But here's a few that, you know, I think we've all at one point or another seen. Anxiety, bottling up emotions, changing personality or mood. Depression, right? Eating patterns changing, either eating or drinking too much or not enough. Fatigue, guilt, shame, self-blame. Heartbeat racing, insomnia, being jumpy or easily startled. A lack of concentration, a memory lapse. Nightmares. Memory lapse is often a big one. Asking sometimes our clients, oh, share with me what, you know, kind of like how your life was when you were 7, 8, 10, 15. And they're like, I don't have a lot of memory, and I don't remember a lot of that. Noted, right? Just something to keep in the back of our mind. Nightmares, along with flashbacks, panic attacks, disturbed sleep. Obsessive compulsive disorders and post-traumatic disorders, quiet and introverted. Relationships are sometimes suffering, or shock and stress. So these are just some, again, that when we see one or the other and there's not a lot of elaboration, we maybe, our mind doesn't go to trauma, but it's, again, being really mindful of some of these symptoms and sort of asking and inquiring a little bit further as we assess, that we might be able to get to maybe something traumatic that's happened to this child, which is why they might be experiencing some of these symptoms. And we'll talk a little bit more about that as well. Next slide, Dr. Carnes. So through the ACEs, and one of the things that we've learned through one of these studies is that 61% of men, 61% of men, 51% of women, that's been reported, experience at least one traumatic event in their life, in their lifetime. Those are huge numbers. 61%, 51% of women, at least one experience of trauma in their lifetime. Thank you. Next slide, Dr. Curtis. And, you know, going back to that thought of trauma. So here we're talking about trauma-informed care. I'm sorry, let me take this back. Trauma, so there's trauma, we're defining trauma. What are some of those symptoms looking like? How to assess in that. The ACEs, how important it is to be able to kind of ask those questions. Now we talk a little bit about trauma-informed care and how the shift focuses from what's wrong with you to what happened to you, right? In our care, in our organization, in how we're being trained to treat our clients. Trauma-informed care approach is to acknowledge that us clinicians need to have a complete picture of a client's life, situations, past and present, in order to provide effective mental health care services with a healing orientation, right? As we're really getting to know our clients, assessing when they share certain symptoms, that as opposed to like checking off a box, okay, next, what other symptoms, what else are you feeling? Like really go into, when did it start? How often has it been present? When do you see that happen? What triggers that certain symptom or response? And because the more information we know in regards to their past, how this has shown up in their past, how it's showing up in their present, really gives us a fuller picture of this person's not only the incidents and the experiences, but their life. And it helps us pave sort of this possible road on helping them with their healing process. Next. Here we have a video, and it probably the first maybe 2 or 3 minutes really talks briefly about informed care, and I wanted to share this with everybody.
Right?
We'll take a listen.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz.
Dr. Carnes, if you mute, I think we can't hear it.
Visits and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider
you,
a
Dr. C.
treatment
We could
approach
pause
that
it
works
there.
for your patients and ensure that treatments and referral sources are available.
That's it?
Yeah.
These changes take time, but each step.
Thank you.
Next slide then.
Yes, please. And
You
you know,
old
as we're
saying,
listening,
don't judge a book by it.
How do I get out of here?
maybe there we go.
There.
And we'll have Nahil start here. But, you know, just to kind of bring that back, it's a doctor talking, but as I was listening to that, I thought there's no difference between the clinicians asking the same questions and providing the same care and being just as caring and empathetic and compassionate as we're assessing and asking someone, how are they feeling, right? And how we go about sort of becoming trauma informed. And part of this presentation is for that as well. So I will pass it on to Nahil.
It's me.
Oh, Yvette, yes.
Thanks, Lily. All right. So as we know, people can have traumas, but they don't really meet criteria for in the DSM, right? So we're going to go over the diagnostic criteria. According to the DSM-5, the essential features of acute stress disorder is the development of characteristic symptoms lasting from 3 days to 1 month following exposure to one or more traumatic events. traumatic events can be experienced both directly and indirectly. So for diagnosing, the DSM lists criterion A through E as the following. You can go ahead and next slide. So criterion A is exposure to actual or threatened death, serious injury, or sexual violation in one or more of the following ways: directly experiencing the traumatic event or events, right? Witnessing in person the events as they occurred to others, learning that the traumatic event occurred to a close family member or a close friend. Right? In cases of actual or threatened by death of a family member or friend, the events must have been violent or accidental. Experiencing repeated or extreme exposure to adverse details of the traumatic events. So for example, first responders collecting human remains, police officers repeatedly exposed to details of child abuse, right? Also, we have to note that this does not apply to exposure through electronic media, television, movies, pictures, unless this is work related, where you're watching these consistently. Stressful events that do not meet the severe and traumatic components of events in criterion A may lead to adjustment disorders, but not acute stress disorder. Next. All right, criterion B states that they would need to have the presence of 9 or more of the following symptoms from any of the 5 categories of intrusion, negative mood, dissociation, avoidance, and arousal, beginning or worsening after the traumatic event or events occurred. Intrusion symptoms include recurrent, involuntary, and intrusive distressing memories of the traumatic event. In children, though, you may notice repetitive play in the theme that happened or aspects of the traumatic event. So for example, if you have, you're working with a child and their play, they were in a car accident, and in play they continuously crash the car. That's one of the things to note. Recurrent distressing dreams in which the content or affect of the dream are related to the event. In children older than 6, there may be frightening dreams without recognizable content, right? You hear of that a lot, where they have nightmares. Next. All right, so we continue with B, and B is long. Dissociative reactions. So those are, for example, the flashbacks in which the individual feels or acts as if the traumatic events were reoccurring. So in children, trauma-specific reenactment may occur in play. So as we said, really crashing the car, look for that in their play. Intense or prolonged psychological distress or marked psychological reactions in response to internal or external cues that symbolize or resemble an aspect of the traumatic events. Next. Okay. Negative mood means persistent inability to experience positive emotions, inability to experience happiness or being satisfied with their life, experiencing loving feelings, right? Generally being happy. Dissociative symptoms include an altered sense of reality of one's surroundings or oneself. Basically seeing oneself from another person's perspective, being in a daze, time slowing. Some people say that they feel like they're having out-of-body experience, like they're not living their own life or seeing themselves, right? Inability to remember an important aspect of the traumatic event, typically due to dissociative amnesia and not to other factors such as a head injury, alcohol, or drugs. And next slide. Okay. By avoidance symptoms, it means efforts to avoid distressing memories, thoughts, or feelings about or closely associated with a traumatic event. Efforts to avoid external reminders. So they avoid people, objects, places, conversations, and activities, right? That arouse distressing memories, thoughts, or feelings about or closely associated with the traumatic event. So they're not going to go to certain places, right? Dr. C was telling me about clients that avoid that had a loved one maybe shot in front of their house and killed or died, and the person doesn't want to avoid entering the house, or they have a hard time going through that area. Did I explain that correctly, Dr. C?
Yeah.
So, all right.
One of the clients, yeah.
Right, with violence, exactly. So arousal symptoms include, let's say, the sleep disturbance. And that also means, that's what we always ask, are you having, what do you mean by not being able to fall asleep? Is it that you have difficulty falling asleep, difficulty staying asleep? Are you restless? Do you just go to sleep for 5 minutes and then wake up? Does something wake you up? Are you having nightmares? Don't let you go to sleep. So that's why it's so important for us to ask, if you can't go to sleep, what is that? What does it mean for you not to be able to sleep well? Hypervigilance, problems with concentration, and exaggerated startled response. Next. So criterion C, D, and E include, let's see, C is the duration of the disturbance, which is symptoms and criterion B that we just discussed, is 3 days to 1 month after the trauma exposure. Symptoms usually begin immediately after the trauma and persist for at least 3 days and up to a month. The disturbance, D is disturbance caused clinically significant distress or impairment in social, occupational, or other important areas of functioning. They can't function normally like they used to. E, the disturbance is not attributable to the psychological effects of a substance, right? It's or medical condition, and is not better explained by a brief psychotic disorder. So we have to pay attention to, are they using drugs? Are they using alcohol? Are they, you know, is it happening at the same time? Did one occur before the other one? So that's why it's so important for us to really assess what's happening. Are they using drugs? Are they using alcohol? Ask these tough questions. You're not being invasive. You're not being intrusive. You're not being nosy. We need to know, you know, we ask, are you using substances? Are you using drugs? Which one came first? Did they both happen at the same time? Did you start using after the traumatic event? Right? Okay, symptoms that resolve, and I know I already say this, but I want to just let you know that symptoms that resolve in less than 3 days would not meet criteria. Okay. Next.
I think it's my turn.
Thank you.
Okay, you guys, so how do we recognize trauma-related reactions? We're going to go through different trauma-related reactions, both immediate and delayed. But first of all, I kind of want to go through traumatic stress reactions vary in severity and often measured by the level of impairment or distress that the client reports. Survivors' immediate reactions in the aftermath of trauma are quite complicated and are affected by their own experiences, their accessibility of natural support and healers, their coping and life skills, and those of immediate family, and the response of the larger community they live in. So really the way they react to the trauma is very determined by their support system, their family, how their community responds to it. And coping styles vary from action-oriented to reflective, from emotionally expressive, or to the extreme to reticent, where they don't express any emotion about it. They don't talk about it. They don't want to. They start avoiding. Next slide, Dr. C. So we're gonna go through the immediate and delayed reactions to trauma, immediate emotional reactions. We have numbness and detachment, anxiety or severe fear, guilt, including survivor's guilt, anger, sadness, helplessness, feeling unreal, the depersonalization. I mean, I've had many clients tell me sometimes they feel as if they're watching themselves, like it's an out-of-body experience. Denial, feeling overwhelmed, and disorientation. And some delayed emotional reactions down the line, irritability or hostility, depression, mood swings, instability, anxiety. Some people become really, you know, they have phobia, generalized anxiety. They don't leave their house anymore. Fear of trauma reoccurrence, grief reactions, and then shame. Emotional detachment from anything that requires emotional an emotional reaction, significant and or family relationships. So it becomes really hard for them to continue having meaningful relationships with the people around them. We're going to go through the physical reaction, the immediate physical reactions to trauma. Nausea, gastrointestinal distress, sweating or shivering, faintness, muscle tremors or uncontrollable shaking, elevated heartbeat, respiration and blood pressure, extreme fatigue or exhaustion, a greater startle response, and then again, depersonalization. Some of the delayed physical reactions, sleep disturbance, nightmares, increased focus and worry about the body aches and pains, appetite and digestive changes, lowered resistance to colds and infections, persistent fatigue, elevated cortisol levels, hyperarousal, long-term health effects, including heart, liver, autoimmune, and chronic pulmonary disease. Next slide, please. So we have our immediate cognitive reactions. Difficult concentration, rumination or racing thoughts, replaying the traumatic events over and over again, disorientation of time and space. For example, traumatic events may be perceived as if it was happening in slow motion, or a few seconds can be perceived as minutes. Memory problems, not being able to recall important aspects of the trauma. Some delayed cognitive reactions, intrusive memories or flashbacks, reactivation of previous traumatic events, self-blame, preoccupation with the event, difficulty making decisions, generalization of triggers. A person who experienced a home invasion during the daytime may avoid being home alone during the day. And then suicidal thinking. We have some immediate behavioral reactions to trauma. Startled reaction, restlessness, sleep and appetite disturbance, difficulty expressing oneself, argumentative behavior, increased use of alcohol and or drugs, avoidant behavior, withdrawal and apathy. And some delayed behavioral reactions could be seen as avoidance of an event reminder, social relationship disturbances, decreased activity level, a lot of isolation, engagement in high-risk behaviors, an increased use of alcohol and or drugs, and withdrawal. And then we have the immediate existential reaction. Intense use of prayer. You will see, people talk about the restoration of faith in the goodness of others, receiving help from others, loss of self-efficacy, despair about humanity, particularly if an event was intentional. And some delayed reactions is questioning, why me? Why did this happen to me? Did I do something to cause this? Increased cynicism, disillusionment, increased self-confidence. If I can survive this, I can survive anything. Some people will experience a loss of purpose, renewed faith, hopelessness, reestablishing priorities, and then redefining the meaning and importance of their life. So as we, do our assessments and get to know our clients, it's really important to keep in the back of your heads some of these common reactions that they can experience due to the trauma. And then we move into the cultural meaning of trauma. Therapists should strive to appreciate the cultural meaning of trauma. It is important for us not to presume to understand the meaning of traumatic events without considering the client's cultural context. Culture strongly influences the perception of trauma. which you will see with our clients. For example, a sudden death of a loved one can be less traumatic in a culture that has a strong belief in a positive afterlife. It is important to recognize that our perceptions of a specific trauma could be very different from our clients' perceptions. We want to be careful not to judge our clients' beliefs in light of their own value system.
Okay. Well, we went through this pretty quickly today. Thought it was going to take much longer. Okay, so if Dr. C, can you go back to that other slide that Nahil had?
Yeah.
So
Okay.
a question for the group, looking at our community and our Latino community, since we're talking about them today, how have you heard them express trauma? What language have you heard them use to talk about trauma? Any specific? Can anyone share an example?
In terms of that self-blame, a lot of the Dios lo quiere, the idea that it's like they're deserving of this, right? So if it's God's will, must be this is what I have to go through.
Thank you, Charles. Yes, that's one, definitely. Thank you for sharing. Anyone else?
Well, I will, can you hear me? Okay.
Yes.
I'll piggyback off what Charles said in terms of that is how intergenerational, multi-generationally, how we see females are trained to, well, that's how it is to be a female, right? And then they put on the, since most of our Latinx clients come from other Latin countries, they're Christians or Catholic, right? And they put this, it's a martyr thing. It's like, oh, she's such a good person to put up with him, her husband, right? The beatings, the alcoholism, the him even being with other women. It's like, she's a good Christian woman. It's like, no, she's not, because you have a very DV, uninformed way of looking at that. So, and it's very hard to question that, because you mean my grandma was wrong to say that about herself or about these other women. It's like, she didn't know any better. Okay. So it's very difficult to do that. And then how do we kind of inform them without saying your grandma was an idiot? Okay. Because, and be very careful, because it can be easily interpreted that's what you're saying, just as the person who will do the other way, and we say it in real life and in novelas, it's like, oh, then I've been the most terrible mother and I abuse the kids and you shouldn't let me see them and all that other stuff. It's like, no, we're just saying we give our kid time out. We don't spank them, right? It doesn't mean that we don't think about it, okay, or imagine it. We just don't do it. And it doesn't mean that you're the worst mother ever because you did spank us, right? And you did do these things. So yeah, there's a lot of cultural, familial things that I've heard it because I've dealt with so many different age persons, right? Who think, and also this is another thing, and I'll just add it here, that so many times people think, one, that to become acculturated means to no longer promote your culture that you come from, right? And as well as your language, as well as your spirituality, your religion. They think that all therapists are atheists, and we're going to, you want to treat my kid and you want to turn my kid into an atheist, okay? And so that all these misperceptions that they have of, time out, different practices and child rearing, as well as just seeing a therapist, that it's only for crazy people, right? And things like that. So, and that, you can only have one or the other. It's like, no, you can be a therapist that is brought up in all these different religious beliefs and still have that and value other people's religious beliefs and practice, and see how can we use this therapeutically, right? Versus we got to throw it all out and just do this westernized version of this is how you heal. Okay. Turn it back to you guys.
All right. Thank you, Dr. C. And is there any terms that you know of that they use to describe trauma? Any words specifically?
You know, as people are thinking about that, I do want to share how anytime I have a client and I'm speaking in Spanish to them, that there's this adverse reaction to the word trauma. Anytime I've had a conversation and I've asked, ¿ha pasado algo traumante? ¿Ha tenido un trauma? Have you had something traumatic happen, or has there been trauma experience? It's like this initial like, no, right? And I've learned throughout the years to sort of start on a, and maybe because it's not terminology they would use to associate with, right? Because what's the definition of something traumatic? Like, it's sad, it's scary, it's that means someone might be X, Y, and Z, broken, irreparable, like there's no coming back from it. Versus using the word like han sucedido algunos incidentes que han sido impactantes, right? Like, has there been an impactful incident? And they're like, oh, well, actually, yes, this, that, and the other, right? And as I continue with, and sometimes I'll ask for their definition of trauma. And normally their definition is like something like catastrophic. And then being able to kind of go in and psychoeducate a little bit about like how that is traumatic and why it's traumatic and how it impacts ourselves, you know, emotionally and psychologically. And sometimes there's that part of removing sort of the stigma from the word, right? That it means something that just there's no coming back from, right? Because if somebody's been traumatized, then there's no hope. There's nothing that can be done.
Yeah.
So incidentes significantes is sometimes a word that I'll use.
And sometimes they've seen it so much in their community and they've experienced it that they don't see it as trauma. They're just like, these are just bad stuff that happens. It's just stuff that happens. So sometimes using the word makes it seem like, no, that's kind of that it's too, like you said, Lily, it's like catastrophic. It's like, you know, something really awful, your house burnt down, tore down, like just, it has to be really, really, really bad. Right. For them to think about it as traumatized. Yes, it is normalized, right? So any experience like, oh yeah, there's a gang that's down the street and they do drive-bys every day. I never thought about it as traumatic in my experience. I just thought it's something that just happens in my neighborhood. My house gets shot at every other week. That's the way I grew up. And I didn't think about it as super bad growing up when I was in that situation. I just know it was really scary. Now, yes, I can see that. Right. But when you're in it, sometimes you may not think that.
Yeah. Like Julie said, it's normal, right?
Mm-hmm. Yeah, exactly. It also goes back to Martin.
I just wanted to add, I've also had some younger clients who will go and tell their parents, this happened to me. And then the parents minimize it. And, you know, they grow up thinking, well, it wasn't really a big deal. I was, you know, someone touched me and they weren't supposed to. So my mom said, just forget about it and move on. So that a child never really had the opportunity to really process what they went through.
Right.
Exactly, Nahil. And just as an example of that, I have had, you know, a client say something like that. And they're like, well, it happened to my sister, it happened to my cousin, it happened to my neighbor. And they start listing like 10 different women that they know who it happened to as kids. And they're like, it's just something, I thought it just happened in certain families. Like, I just thought, you know, it doesn't feel good. I didn't like it, but I just thought it happened. You know, so using the word trauma, may not, that's not the word that they would use. We'd have to really dig a bit deeper. So back to the question. I didn't see anyone in the chat throw out any other words. So one of the things that we would look at is some clients use the word susto. Tuve un susto, right? Oh, sí, cuando yo estaba chiquita tuve un susto tan grande. So when I was little, I had this, right? Susto, it can mean trauma. So we have to think really ask what that means, what that was, because there's a spiritual component to that, where it's seen as your spirit left your body at that time. Now you need to do the work to regain it back and get yourself back, right? So think about it that way. Yes, it can mean I had, something really frightening. It was a fright. And it can also mean my spirit left because it was so bad. The fright, that fright was so awful, right? So we're going to do that work. So when we ask about spirituality, when we ask about what does justo mean, can you tell me more about what your experience, what happened? We want to know, do they just need therapy, or do we also need to connect them with whatever spiritual guide, healer, medicine, curandera, whoever we need to link them to help them regain that spirit back. And they're doing the emotional work with us as well. So you can work in conjunction. So just think about that too. Any other, yes, Doctor.
Yes. I wanted to add something to what we're talking about here, that the psychosomatic responses are also very real with trauma and certain, populations, like in most Latino populations, it's actually more common for somebody to say, this hurts. And so then I go to the doctor to get that sorted. And then the doctor says, that's actually not, we've run all the tests. That's actually not something physiological. That's more, psychological. And I think unpacking that also in session can be really helpful. Is, how are you feeling today? And, how's your body? Do you have any pain? Even though we're not, medical physicians, it's important to ask about how they're feeling in their body, because many times people will experience anxiety, in terms of, stomach issues or headaches and that sort of thing. So the psychosomatic's really a good indicator too.
Yeah.
That is so true. How many times do we stop to just ask as they're sharing, like, oh, I feel nauseous every day, or, I have headaches and heaviness in my chest, however they describe it, that we sort of dig back and ask a little bit more, what does that mean? Where's it coming from? When did it start? What triggers it, et cetera, right? Like, how do we ask about those somatic bits and pieces of it? I just saw somebody add another word, cosas feas.
And
Gabby,
es
thank
algo
you.
malo también.
Algo malo que ha sucedido. Yes. Those hush situations, yeah. Eventos.
Yeah.
A lot of times also, and I wanted to add this earlier, I think, Yvette, maybe when you were talking a little bit more about, maybe how do we know, or how can we kind of uncover some bit of trauma with client, or how do we know it's, or with the words terminology. And sometimes people don't, it's the things that you don't talk about, what is not talked about at home, what's taboo. And that can be a very common thing, that you don't air out your dirty laundry, so to speak. And, you don't talk about your problems to other people. And so then there's that stigma on, it's a barrier to healing, because a lot of people that I've treated, a lot of Latinos, have also said, oh, well, that's in the past. Eso está en el pasado, and I want to leave that there. And so then there's a lot of the psychoeducational component that comes into play, where you say, well, in order for the healing to occur, we kind of have to go over that. And, it's not going to affect you negatively. We're going to do things that are called, grounding techniques and that sort of thing, so that you understand that you're in a safe space. But there's a lot of learning that needs to happen in terms of, this is a safe place for you to talk about trauma and modeling. This is how you do it.
Yeah. So as we talk about from the very beginning, we had said to them that this is confidential, and defining that, and how do we, and basically let them know, well, I'm not going to talk to your parents about this. I'm not going to tell your husband, or other people this, right? It's like, there's certain people that you can trust and they can't tell you things. Your priest, in a confessional, they can't tell. Your attorney, they can't tell, right? It's like, so we're kind of like that in terms of this is a safe place, and providing that safe space, because, which is, nobody's ever told them that that's what therapy is. It's a safe place where you can talk about stuff. And then they surprise themselves because we create this, if we create this environment, they're surprised, like, what did I just say? I just told you something that I promised I would never tell anyone, right? Or I only did it that one time, and this is how they responded. Like I told my mom, and she said, "Ya cállate, eso pasa," right? Just don't mention it to your dad, or he'll kill the guy. It's like, okay, that's all I got. The only thing that told me that what that guy did was not okay, but it didn't tell me there's a way to solve this. There's a way to deal with and process this. Now this is what we can do. So providing that environment, sometimes it's like they'll surprise themselves. It's like, what just happened? I just told you something, and they're telling us themselves. It's like, and I feel like a weight was lifted from my chest. I feel this and this, and you see how you've been carrying this for a long time. I wonder what else. ¿Qué más hay quizá que estás cargando? Let me help you unburden yourself. Let me help you get rid of that. And that was disgusting, by the way. That it makes sense that you don't want to think about it and talk about it, etc. So, because it is that terrible, it is that bad. However, it's time that you put it in its proper place, and it's time that you begin the process of healing. And it's also, let me help you see that your mother did that because she didn't know any better. She did what was told to her, and so being able to give it a context that, that we do know better, right? But doesn't mean that we're better than them. I mean, I think that there's that continual thing. It's like, but I think also we have something available to us from persons who come from these other cultures, and I don't just think Latin, it's also persons in the Middle East, etc. And that in the hill, it's like where they elevate professionals, they elevate teachers in a way that Americans don't. It's like, oh, I know that before I had my doctorate, they were calling me doctor. It's like, I didn't correct them because they were just saying, I trust you. Okay, I'm giving you this space. I'm like, I'm not going to correct them and say, didn't I tell you I'm a doctoral student? I'm not a doctor yet. It's like, I don't need to do that. I need to hear that they're giving me this, just like all of, and as you all, your trainees, these people are trusting you to, if not know what to do with it, at least know what not to do with it. Okay, and that's very important because, all of us licensed are much less green, right? And you guys are really green. That's not a bad thing. That's just real. And I know back when I didn't know what the heck I was doing. Okay, dealing with in the VA in Waco, Texas, 20 whatever early years old, right? Dealing with these, persons from World War II, Vietnam, etc. And the field didn't know what the heck it was doing either with PTSD at that time. It was very infant. So, being able to see, it's like, but to give the people a space that they can talk, where they can use their own word to describe. Like people say, me sentía, when they finally start talking about, y me sentía ido. I felt I wasn't, I was beside myself. That's right. You were dissociated. You were seeing this happened to you, right? And or when you acted that way, you weren't being you. You had an out of body experience, right? So being able to describe that and talk about that, and it's like, yeah, and now you think I'm crazy. No, I'm certified to label people as crazy. You're not crazy, okay? What you went through was crazy. You might seem, but you're not crazy. What you are is you're affected, maybe not using the word trauma. That has pasado por algo muy pesado, muy difícil, muy doloroso, right? Something that you can't forget, but you've tried to. Is there something that you've tried to forget and you haven't been able to? Is there something that, that has, when we ask them about their, it's like, oh, issues with sleeping. Has there been times that you've awakened and has there been recurring something and you haven't been able to tell somebody? Because if I tell my husband that I was raped before I married him, you know what that means? It's like, it might to him, but not to me. And we actually don't know that that means that to him. Okay, we don't, you know? So being able to, talk about that and use these non-clinical terminology, right? Because it's not about them leaving and being able to say, oh yeah, I was, and how many persons say, you ask them, were you ever molested? And they're like, no. Okay, not the question to ask. How were you introduced to this world of we call sexuality or sensuality? Oh, and they would say, they tell us, and it's like that. Can you see how that was disrespectful, inappropriate?
Mhm.
You wouldn't want that to be your daughter, your sister's introduction to that world, right? Oh no, because I would cut his testicles off. But if I asked you before if you were molested, it's like no. You see, so these some of the terminology that's it's done too clinically, it just scares them off and it says, of course that, or were you molested? No, because there wasn't penile vaginal penetration. It's like, oh, so that means no boys can, if they're that clear in their definition, boys aren't molested because they don't have that body part. It's like, so all these different, ways that people look at things that are adverse experiences have compounding impactful effects on them that we are there to treat. The persons that do this and use the ACEs, that video is really good. That's primarily for persons not in our field. That's for physicians, dentists, all these other persons, right? That can do that and then send them to us because then we're going to help process this. But there was a therapeutic value in being able to tell somebody this and that even have them ask you this question in an environment that says, I really want to know. I'm not just doing this to check it off, right? So all that real important, like I said, these terminology and these ways that are described by very indigenous people around the world as, being beside yourself is something that's very common. Having that out of body experience because your mind needed to leave, as your body was, experiencing this unthinkable, untellable, undescribable thing, right? That now PTSD'd you. Do you have PTSD? What do you have? What have you experienced? Let's go deeper into this thing that you have, right? Or this thing that we know about, right? Or the things that was happening, like you said, oh, you grew up where? At what time? It's like, oh, so it's like you experience drive-bys, you experience seeing body parts on the street, you experience this, right? Just as one of the things that I remember so well, because I dealt with young persons in the 80s that were high school kids, and some of them had already been in war in Central America. And then there are other kids, and now we have parents and grandparents of kids here that are from Central America, and they went through war, civil war, and where there were bodies for days in the little plaza and all that. And they're like, but they deny it. They deny that affected them, right? That has anything that they've ever been, traumatized. It's like, but oh, you were at what time? Tell me, were there things that happened that luckily don't happen maybe as much or anymore in where you grew up or when you grew up? It's like, oh yeah, luckily, if we go down there, we're not going to see that, but we're going to see the gang members doing these certain things that are similar, right? It's like, and other people say, oh, that really affects people. That really gets in the way, and that has these effects on not just them, but their children, right? So there's a lot of denial or minimization because it's so, like you said, Yvette, it just happened on a regular basis during this time, and so that we have because it's within this lifetime that we have. And recently in Mexico, they're still going on, right? It's like you have bags of heads being thrown into certain places because the narcos fighting each other and all this other stuff. And it's like, because it's happened in certain areas very commonly, it doesn't mean it doesn't fit the criteria technically for PTSD. You know? So yeah.
So it goes, yeah, and then you just reminded me, Dr. C. So one of the reasons that, at least in my group, I stress about the immigration, asking about their immigration or migration experience, is because of that exactly, right? We don't know their stories because not all of us are able to just hop on a plane and move to another country with our luggage, right? There are things that happen, events that happen to us or to the families that we work with that led them to make the really difficult decision to leave their country of origin with all their family, where, you know, that's all they know, with a different language, and then come over here. And we need to ask, what was that like for you, right? What was that experience like? Some of them go through the coyote, and that's a really, really traumatizing experience for some people, unless you have a nice coyote, but it can be. So, you know, asking about that, what was that like for you? What was that experience? How about your parents when they were sometimes they're little and they don't know, and, you know, they didn't witness anything, but sometimes they're teenagers, or even the kids that are left behind, right? We have kids who grew up with abuelito and abuelita in their country of origin. Then when they're like 15, 12, the family goes back, you know, and gets them. How did they get here? What was that process like? What was that abandonment like for you for all those years? Why do you not have a good relationship with your family now, right? All that stuff, it affects somebody. So really diving deeper into what does it mean for them? Because they might not have thought about it as trauma. They may not experience it like that, but we see in certain behaviors that they have that it does affect them. Okay. That. So in that, in the narcos, in all that, what was that experience like? Was your neighborhood hot? Even the kids that we have here that we know that live in neighborhoods where they're gang infested or low income, or where they have a lot of that, you know, is the neighborhood hot at the moment? Are you having drive-bys at the moment? Or, you know, is it pretty stable? The gang members stay at one corner. Do you avoid that area? We ask our clients, go on a walk, go exercise. Don't we say that? Go out with your family, thinking that they live in our neighborhood, you know, pretty safe, but they may not. They may not feel safe pushing the stroller down the street. They might not feel safe walking to school. Do we ever ask a kid, do you walk to school? What is the neighborhood like? What is that walk home like for you? Right? So it's just things to think about, you know, and just explore that with our clients, because some of them don't live in very safe neighborhoods. And we got to be real about that.
Yeah, and I'll throw in another case that I had. I saw him as a young, in his 20s, and it's how to explain. It's like he had all these different things from Honduras. His mother came here, and she never went back for him. And the grandma who finally got fed up and said, "Okay, send me the money, and I'll send this kid over to you." And she says, "Okay." She didn't come for him. She sent money and had a coyote take him from Honduras to the United States. And he was age 7. Okay. He got stopped in Mexico City. He went to jail in Mexico City. Before that even happened, he had a gun put to his head. Okay. He had all these different things. This was a 7-year-old boy. And then he made it back home, back to Honduras. He didn't make it here. And then the grandma says, no, I'm not doing that again. They didn't know about all this stuff that happened. They just knew he didn't make it, right? You know? And so the grandma says, no, if you're going to take him, you're going to come and fly in and fly him back. And at that time, they could do it. And he did, but he was very disconnected. He lost his mom, who was his grandma. Mom would come periodically, very periodically. And it's like, okay, they say she's my mom, but just somebody I know who she is, but we don't have this bond or connection. And so he's very traumatized. And once he gets here, he's with mom and her new family and his stepdad, because his biological father was who knows where. And she never bonded with him and never liked him. Okay, so he had trauma on top of trauma, loss on top of loss. And so it made sense that this kid would self-medicate, right? And, or if you're gonna, you know, if you're gonna pick on me, I might as well give you a damn reason to. All right, I am gonna use the drugs. I am gonna, you know, since you already call me all these things, you know. So yes, there's so many different things, and just because the family says I know what happened doesn't mean that they know what happened. Okay, it's for them to again have a safe place. Say, tell me, what was it like? What happened? Describe that process. Okay, or it's like you were in Tijuana. How long? They know Mexico City and they know Tijuana a lot better than they know their, you know, their city in Guatemala or El Salvador. Why? Because they were there a long time and they were in the slums. They were in a very rough neighborhood, just getting by. You know, so yes, finding out about more detail about, you know, how long were you there? Where was it? And the thing is now that we can on the internet literally look at it's like, where? It's like in a pop up a picture of like, you know, Google Maps. It's like, whoa, I've actually done this. Like, is that the ranch that, you know? And that's the corral that where you ran away and but you didn't go very far because you're only 8 years old in that little town. You know, so we can now have not just their descriptors, we can say, and that'll cue them, right? To, yeah, that's what happened. That's what the positive people, and these are the negative people. You know, so there's so many, my point is there's so many more details that we can pull out of them. They need to know that we are interested. This is important. And it's not because we want to label them as, like you said, damaged, right? Or unfixable. No, they are very resilient. They're very strong, right? They have a lot more strength and ability in them than they think. And it makes sense that this is going to affect them so hard, because what we know also about trauma and the data says that it's much more likely to have PTSD, you know, symptomatology that's then diagnosable if it's a human, you know, a human action. Somebody decided to shoot, to stab, to do all these things, right? Versus it's, hey, in Guatemala, if you know people from Guatemala, they have a lot of earthquakes. We think we have earthquakes. No, they have a lot of earthquakes. And they're like, oh, that was nothing. But wait a minute, this is big old fissure now here. It's like, yeah, but we can just jump over it. It's like, you know, it's, you know, but that's natural occurring. There's like, hey, it's just something that happens in nature versus somebody, you know, blew the 10 towers down. Somebody, you know, did that thing in Boston Strong, where they, you know, they decided to put those things there and kill and maim. You see? So those differences of oh, they must be traumatized. No, it's difficult, but hurricanes happen and earthquakes happen and floods happen. But what was more traumatizing was that, you know, this wall that came down because it was not like that thing in that building that went down in Miami, was that? Because of that, you know, human, you know, they cut corners, they didn't spend the right price. So in a certain way, it's like you set up innocent people to die, you know, because of your, versus if it would have just fallen because, you know, anything would have done that to any wooden house, let's say, or something like that. So yeah, there's a lot of details, and very important to see that we're giving people an opportunity by diving in and asking these other questions, an opportunity to divulge, to let go of, and they don't even know, they say to themselves like, oh, I feel so much lighter, right? And even then, and then they're apologizing, right? And my rule of thumb is you are not allowed to apologize. You can thank me for listening to you, but you're not doing anything wrong or bad by crying for you, for your sister, for whomever it is. It's just, you're being human. You're being a very compassionate, caring person. And that's why sometimes they'll see me tear up. I'm not going to apologize. I'll say thank you for sharing something so intimate, so difficult, so human. Okay. And I'm human. So you're going to see a reaction from me. Okay. So.
Thank you, Dr. C. So the power of really asking more about their stories, right? And something that just came to mind with the Latinos I've worked with is Sometimes they'll say, if you ask them, how did you meet your husband? Oh, pues me robó. How many times have we not heard that, right? And you're like, what? Te robó? Oh, can you explain to me what that means? So in English, he stole me or he kidnapped me, he just took me. And they'll tell you their story if they're ready to tell your story. Sometimes they will brush it off. I think most of the times I've had them brush it off, pues, pues ya saben, me llevó. I was walking down the street one day and I know that he liked me and he just took me. And then they brush it off like, yeah. And then here I am, but 20 years later with 5 kids. Hold up a minute. Hold on a minute. Let's go back to that. Right. Because, we talk about them just normalizing, oh, pues sí, eso pasa. That just happens. Asking about their stories, So, that's just something that came up, and that's usually, and that mind-body connection that we were talking about, so important, because they get, oh, how long have you been getting headaches? Oh, well, I've always had them. When did they start? Right. Well, there's no really medical reason for it. So it's a lot of that, you will hear that. And I get that, I think, a lot with depressive symptoms. They won't say they're depressed. They'll say something hurts. They won't say they have trauma. They'll say something hurts. Or anxiety, they won't say that. They'll think they're anxious. So just look for those little nuances and ask. We're going to say something, Lily. Go ahead.
Yeah, thank you. And as we're, talking about this, I'm also, the things that came to me too, and not that we brushed over them, but it was like part of how it's not our go-to, right? So, Dr. Carnes is bringing up like the Twin Towers and the Boston and, the massacres in Florida and stuff like that. And, I'm thinking of like what other traumatic pieces can our clients, or have our clients shared like very sort of like in passing, and sometimes we don't catch it, right? So, porn, how many of our children have been traumatized by being exposed to pornography really early on, and like all of that piece that follows with just the confusion, the misunderstanding, and the assistance that they need to sort of like surpass or not get stuck in certain places, right? When somebody tells you about like a traumatic childbirth that they had, right? To a child, that's something that miscarriages and abortions, right? How many of these stay with, and we always tend to, inquire with the women and like what impact they had with them, but the male figures, right? Like the fathers and the husbands, and how sometimes we don't inquire about how that miscarriage, their third miscarriage, how that impacted them. And the part of like post-traumatic depression and how that affects our children in regards to the attachment that they have or don't have with this parent because of this that they've experienced at a very, very young age, that they might not even remember. They just know they just have this adverse sort of reaction to their mom, or they're really either clingy or really detached or whatever it is, and not knowing like some of that story and that history, right? And how do we inquire more further, dig deeper into, and what else happened?
Or does somebody else know about what was going on in that time? Has there anybody told you about how your mother and because I just do that automatically, your biological father, met each other, or what were the circumstances around your birth? My mom never said anything, and I don't even know who the dad is. I don't even know who my biological father is. It's like, but your mom had an older sister she was really close to, right? These other people, or there are some other people that you do know on your biological father's side that are pretty healthy. It's like, what have they told you? What can they tell you about that situation? He was, the black sheep, the really messed up person in the family, but the rest of the family was pretty healthy. But what did that tell you about, your mom? How old was she? How old was he? What can that, inform you about? What's the likelihood that was like not healthy at all, given that she was 15 and he was 25, and married at the time, so being able to, get into, again, get it past this, we don't talk about it thing, it's not okay. Well, here it is. Here we do. And even asking, and I ask that question, especially as therapy goes on. So what do you not want to talk about today? Okay. So what, we mentioned some things like, so what are some things that your family says, no, that didn't happen, but it did, so being able to just directly say, we're going to talk about those things that, they don't talk about there, but we talk about here, we're going to unpack it, so being, and again, the more comfortable we are, and it takes time, it's like to ask those questions, they're going to pick up on it. It's like, you're not nervous about this, you can handle it. Because some of our clients are like, they're so concerned, well, I don't want to burden you, you do this all day. Oh, I don't want to add to your, the stuff that you got to deal with, give you my junk on top of all that other junk. No, give me your junk, because I don't keep it. I toss it out. I get rid of it. Okay. So you're just asking them and giving them permission and letting them know, I can handle it. You've been handling it. Let's get rid of it. Let's put it in its proper place.
And our communities are
There's-
sometimes so respectful of us as providers that they don't want to burden us. They want to just not give us their load because of that. So keep that in mind. Nahil, I know you have to, you want to say something. I just want to point out Charles talking about nonchalant and people just being comfortable with, traumas or difficult situations in their lives, that he said, my abuelito used to be nonchalant about being chased with a knife at his wedding by his father-in-law. There you go. Thank you, Charles, for that example. Yes. Right. People just say, well, that just happened.
And they
Sorry,
might even laugh
No problem.
about it. Oh yeah, I remember that. It's like, no, that's nightmare stuff,
Right.
man, for somebody.
Yeah.
I just wanted to add one thing about how do we gather this information? How do we ask these questions? One thing that I love to use is a timeline of their life as, I'm getting to know them as we're assessing them. We can develop a trauma timeline or just a timeline of events that they thought was important to mention, ways so you can kind of keep track of what they've experienced throughout their life. So that you can go back and we can go back and kind of talk about it further, the more that you build rapport.
And then a timeline's really useful because, we've all had those clients that have had multiple traumas throughout their life, and it's really difficult to put them all into perspective or figure out which one came first at what time, what was the circumstances around that. So you need something in writing, and also so they can see it if they're watching it, right? And that's very useful too.
Yeah.
And I would add, and so that we could later on say, psychoeducate them. Well, that's how you understood it because you were 6. Okay. And have you been able to process it with a older, more mature intellectual way of processing it beyond 6? There's a certain way that our brains work at 6. Think of 7-Eleven. It tends to shift again at 11. We're able to think of it in a little more complicated way. And then 11. And we know some people that they don't do it till like 25 or 35 or later, right? But they don't really mature in their way to think about things and abstract things, and not be so black and white. So being able to see that that's going to happen, right? And know that your client that you're dealing with that's really young, they're gonna, and maybe helping those persons around them, they might seem like they're okay, but they might start thinking about it and asking different questions a little later on. It doesn't mean that they didn't do the work or we didn't do the work now, but that's just a part of that maturational process of, hey, wait a minute, I need to now understand it or process or investigate it differently now. Okay. So being able to be ready to do that, very important. Okay. And something else too, we talk about how things, what things slow down. Well, a manic brain, okay, operates at 6 times the speed of a non-manic brain. That's why manic persons are, they talk about that things slow down, and they're the smartest person in the room at that time because they're seeing things so clearly and they're operating so quickly with this manic hyperstimulated brain. Okay, so they're able to do that, which other people need to be trained in how to slow things down and operate that way. Okay, so that's a part of what they're remembering. You're remembering this accident in slow motion because you kicked in, your biology kicked in that adrenaline. Okay, and that's why that did happen. According to your brain, it went into hyper mode, and so so you did see that flipping and that stuff happening really slowly because your brain was operating like that. Okay, so it helps them to understand, oh wow. And so it's kind of like, the Matrix and those scenes like the guy, they're doing these things in slow motion and all that, they're happening in real time, but they're just processing it in that hyper brain, space. Okay, and sometimes people, they've had to do that so often they think, what's wrong with me? Okay, and they might dissociate it too, just as again with bipolars, that with their manic time, they might not remember it. They have this gap in memory. They're not lying. Their mind didn't process it, quote, normally to be able to fit it into a memory space. Okay, it happened. So they don't remember it. Okay, so just as too with this PTSD delayed, it's like, and now they're getting the flashbacks, or not flashback, they're actually, now experiencing this thing that's like, oh, I never knew that happened. Well, it was back there and now it's coming in, and it might come in regular mode or it might come in slow motion mode. Okay, and so that's just also an interesting thing of working with more and more traumatized persons, clients, and getting into the details of them telling us about those experiences. Whereas, and as a not very green therapist, these are people that have had therapy, quite a bit of therapy before, but they never got asked more questions to get into. Tell me about that. Tell me what happened. Let's cue it. Let's ask some questions about after. Let's ask questions about before that will trigger, so we can finally go through this and process it and integrate it, right? And I'll just add something else. It's like, this is very difficult work to do, and that's why so many therapists don't do it. They have the training, but they don't do it because it brings up too much stuff, and it's really painful to see your client drop down to that 6-year-old that was molested severely, brutally. Okay, that's not easy. It's hard. Okay, or to tell you about the things that they did in that mind state, in that environment, in that situation, but what else was I going to do? So, back to you.
All right. If we're good, we can move on to the next slide. Well, before, does any of the students have any questions? Comments? Yeah. Okay, feel free to put them in the chat. So we did put a couple of books up here that might be useful. I know we've discussed some of these in supervision with your supervisors. The Body Keeps Score. Oh no, the Body Keeps the Score. I always forget the in that book. It Didn't Start With You. There's also for our Latino clients, Cultural Foundations and Interventions in Latino mental health. And Cultura y Bienestar is another one that'll give you more of an idea of how to fit in how other providers fit in mental health with, let's say, curanderismo or other spirituality and other practices. And that gives a lot of good examples. Next one. All right. And Charles has a question. Let me just address this one. Multimedia, so other movies that'll give you some insight into what we discussed today. I think one that just came out is Rita Moreno's story, Just a Girl Who Decided to Go For It. And that one's she talks about her trauma, her experience, and it goes, what I really like about that one is she talks about her own trauma along with the racism and prejudice at the same time that she experienced. So it gives you that insight from also a woman's perspective, right, here in the United States. Maid, Mariposa del Barrio, Little Miss Sunshine.
Yep.
All right, and then let me see. We have one question. So I'm Charles. I tend to struggle with how to balance the degree of grounding with psychoeducation about trauma. Anyone want to talk about that? I tend to struggle with how to balance the degree of grounding with psychoeducation about trauma.
I think for me, I'll share in that a little bit. For me, it kind of, there's a, and I don't know, Charles, if you've looked into TFCBT, the trauma focused cognitive behavioral therapy.
I'm familiar.
Familiar. I like the structure and I understand the balance because that's your question, right? So I like the structure of the TFCBT because it goes in to sort of actually give our clients the skills to use when they're feeling anxious and triggered, right? So like in the beginning, I do a lot of like just giving interventions because I know they're going to be able to use and access those as we're talking about trauma. And then grounding, I really gauge on each session, per session, like how much grounding is going to be needed, either at the beginning, because sometimes we come in discombobulated and we want to start grounded, and or because sometimes I start and end with grounding because we've talked about something really heavy and I just sort of like want to reintegrate them and before I let them go. So the word is balance. How do I balance, right? So as you're doing this work more, and I think it all takes us our own sort of time and journey to kind of get to know what works for us. One, right? And then the person that's in front of us, our client, like what is it that they're going to need constantly? And sometimes you have to pause the trauma talk to go back to psychoed, to go back to coping skills, to go back to grounding, right? So it's kind of like learning your own style of that too.
Mhm. I guess more along the lines too is that with previous experiences with trauma, and I say this from learning what not to do, I think I went into the processing of the trauma story too soon.
Mm.
And so that's kind of what I'm trying to learn from.
Yeah. Yeah, I get it in terms of sometimes, you know, the client is ready to jump in, right? It's like, wait a minute, this is deeper. Okay. You know, let's put a vest on. Okay. So being able to, you know, when you know they're already, my rule of thumb is if they're coming in with any anxiety symptomatology, they've already talked about that I've had anxiety attacks and all. It's like, okay, I'm going to teach you, you know, progressive muscle relaxation with visualization. That's my thing. Okay. But you can teach whatever other grounding or relaxing, focusing techniques so that, all right, we're going to do it. And then we'll get to, wait a minute, perhaps there's my antenna saying you've got some stuff that needs to be processed and dealt with. So that now they already have, like you said, Charles, it's like, instead of, oh, let's get into it first, I have this because as they're describing their stuff, right? And I'm going to be the one that's saying, all right, stop.
They become flooded.
Yeah. So being able to hold off, we don't need to do it all today, right? And also being able to see, you know, sometimes we do the best we can and it still was very overwhelming. And this happens, it's like they forgot their next session. And there's a client that's really consistent and all that other stuff. They just need a therapy break, okay? Because
they're overwhelmed.
Right. So being able to say, you know what, when we come back, we're going to just review what you already did, not go deeper. And we're going to start and end our session for sure with this grounding and relaxation technique. So being able to give them these things and give them the homework in between that I'm going to, you know, I'm prescribing this for you, that you are to do this X amount of times a day, every day, whether you think you need it or not. And my thing is, and you use it to go to sleep. This is what you, and that doesn't count as one of your practices that I've assigned to you. This is how you go to sleep. Okay. So giving them these things that you already know. And then I'm also cueing them. I say, take a breath, and I take a breath, and I make the sound. Okay. So being able to do that because they're mimicking us, just like we're sometimes mimicking them, with clients that you've had. It's like, oh man, that client is so draining. That client is so, man, it's like, you didn't take a breath, did you? You didn't, wait a minute, let's slow down. You didn't do that, right? Or this client is so depressed and they're like, oh gosh, it's like,
Checking in
I'm
with
gonna fall
ourselves
asleep.
afterwards of like,
So being able to, how do you keep your energy level up and help them not get so sucked into that muck, right? At least with you. So yes, so being able to know, it's like with certain clients, I'm going to need to prep them, okay, and get them ready before we go deeper. Even though they already started, it's like, but we're not going back out there without making sure you have a vest, okay, and where some other things are that you need for flotation or whatever, right? So just that, it's like, so it's just good for them to learn these different things and learn this is what, when you cue them, they know what you're talking about. Okay. Or like, just like, where are you? Who are you with? What's my name? Which are really simple things. It's like, and they go, oh, you're helping me not go there, right? Into that 7, 8, 9 place I talked about, 10. You want to get me back to a 6, 5, 4. That's the window where we can do therapeutic work that sticks, right? Because if they do this stuff and they're 8, 9, 10, they don't remember it. Okay, it didn't happen. It's just like, again, talking to, oh, I talked to my dad, and he apologized and he said all this stuff and he cried. He was drunk. It didn't count.
right,
It didn't count.
right.
If you would have talked to him and he's sober enough, then we could say it can count. So
Thank you. I appreciate the insight because we learn from our mistakes and we learn
yeah,
from what doesn't work, right?
yep. And
So
you
I
learn from us
appreciate,
from what works too.
so I really appreciate the insight and thank you everyone to
Sure.
give insight from your experiences.
Mhm.
We have one more question. Thank you, Jaylene. She says, I wonder how religious trauma could be addressed. Example, some of my clients grew up in very religious households, so mental health was completely ignored because all they needed to do is turn to God. Or they have had traumatic experiences due to the church. In the Latino culture, the Catholic or Christian religion is a big part of the home family.
Yeah, a lot. And so being able to address that directly and say, every culture, religion, etc., has unhealthiness in it. Okay. So being able to see, it's like, so how do we, there's hyper religious people, right? And there's people that use it to perpetrate with. Okay. So being able to acknowledge that, okay, because I've had people with all kinds of different religions and they tell me about their priest, their Buddhist monk and all that, and they sexually abuse some of the people under their care. It's like, it's not always, oh, forget it, all of them. No, we're not going to do that. But say these were unhealthy people that unfortunately went into and utilized that. They cloaked themselves with that to do more damaging stuff. Okay. So being able to talk about that and now, and then talk about people that I know that are religious. They're nuns, they're priests, they're pastors, etc., and they're licensed therapists. What does that tell you? You can meld the two. Okay. And so the people that say all you need is enough prayer and enough faith and enough belief. Sorry. I mean, okay, Christians, those that know more, what was Luke before, during, and after his being in the presence of this person in that book? A physician. He didn't stop being a physician. Okay. I mean, there's all kinds of different examples of people who, have scientific reasoning and belief and all this other stuff and are still religious people. Okay. So being able to, see that it's not one or the other, but again, you know, you can be very damaged by people who are extreme and aren't able to counter or balance. Okay, the reality is, you know, and we know that there are people that they go too far, and I mean, look at how many persons are dying now of COVID because all you have to do is believe. They're dead. It wasn't because of lack of faith, okay, or whatever. So it's very difficult because we're not to talk about religion and money and politics. Well, I don't know about, maybe it doesn't do any good to argue about it, but we can approach the subject and say, how do we parcel out what is healthy, what is unhealthy? Okay, and say that it's not my area of expertise, but I know people who have that expertise. Like one of a good friend of mine who's a joker, he's like so dang funny all the time. He's a priest. He's a clinical psychologist. He did his doctoral training at what's that hospital in Washington, D.C., where the guy that tried to kill the president was, in St. Elizabeth's Hospital or something like that, in Washington, D.C. Anyway, he did it there. The whole time he was there, people had no idea he was a priest. They had no reason to know it. You see? He was able to, you know, navigate that. At times he's Father Brian, other times he's Dr. Brian, you know? So being able to see, it's like, it's not one or the other, it's how do you healthily do one or the other or both. And it's really hard to navigate because a lot of times people are coming from a place, it is one or the other. And one of my sayings is, que haya un loco y que no haya dos. If you try to convince somebody that's that extreme or that psychotic or delusional, now you have two crazy people. Let there be one crazy person, not two. Okay? That they're in that space. Joining them in that space is okay as long as you know you're joining in that space, but you're not trying to take them out of it. You're just wanting to know more about what that space is like. Okay? So, but how do you guys handle it? Nahil? Really?
I think in a similar way for me, just addressing that I usually start off with, you know, there's the bad apples in everywhere, like in the religion, in our communities, in our culture. Like there's no perfect anything. There's no perfect family. There's no perfect culture, no perfect religion. And that opens that conversation like that, right? And we have to think about like that black and white thinking at the same time, and then address things that way. That's usually my way in. And I do, you know, for certain clients, I tell them, I say this, I don't want to be disrespectful or anything, you know, but this is maybe something that we'll need to explore a bit more, you know, asking for their permission goes a long way at the same time. But I think being respectful of their their religion and their values, while still addressing those negative parts of it.
Mm-hmm. Yeah.
And then Charles has a comment here. He says, I was once told that abusers have awareness of therapeutic principles. The difference is they use our knowledge to perpetrate.
Yeah.
Yeah.
Perpetrators are better at reading people and just better at reading people than I am, and it really is annoying. Okay, they understand psychological concepts and how to misuse it better than most therapists. Okay, but they're using it as a tool to do harm, just as a surgeon could, you know, that surgical knife can be done. You can do a lot of great things, but you can also do some very disgusting, terrible things with that surgical knife, you know?
Yeah. Have you guys ever done a Google, gone on Amazon and looked for like assessment tools or books on psychology? At least on my feed, one time it brought up, you know, how to use psychology, like, I don't know what the term was, but really to harm. I don't know exactly what, but there's books out there. I don't know if you guys are familiar with that term that they use, but it was that type of literature. It's really interesting. Oh,
Wow.
yeah.
It's reality.
Yeah. All right, we can go to the next slide. All right, so there is a quiz. Oh, there's one more comment. I once took a CEU on narcissistic abuse during COVID. Yeah. Okay. So we are going to have like a quick quiz for you. It's like 9 to 10 questions that you will, the questions are here, but you'll be emailed these questions, complete the form, and it's nothing that we didn't discuss. And once you complete it, send it to your supervisor. Am I correct?
Yeah.
Any other input? Okay. All right, so this is required for everyone, whether it was recorded or you were here live. Okay, and next slide. That's it. Thank you, everybody.
Okay, thanks, everyone. Thanks for your input. And next month, do we actually have the date? Does somebody know?
We do. It was emailed to them, yes.
Okay. So it's usually the third Thursday of the month, right?
November 18th.
Yeah.
November
okay.
18th.
Because the third one is Thanksgiving next month. So, all right, so Thursday, November 18th, right? 5 to 7, right? Okay. All right. Thanks, everyone. Good night. Have a good evening and the rest of your week. And stay safe. All right. Bye-bye.
Thank you.
Thank you. Good night, everyone.
Bye, good night.
Thank you. Good night.
Everyone off?
Yeah.
We can stop recording. Yeah.
Yeah. I'm gonna make sure Ben stops it so that he's gonna edit it and all that stuff. I don't want to push the wrong button and it's like, Dad, you erased it. Right. So,
Awesome.
okay. So I think it's just us here. So what do you guys think real quick?
That's good.
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 Good way of like stretching it out, Yvette. Like by the time we realized we got through all the slides, you were like, all right, let's go back. So that worked out really well.
I was like, think fast, question. Oh my gosh. And it was one of the quiz questions. So I was like, all right, that's what we got, guys. This is way under an hour right now.
Yeah.
Oh, well.
That
Yeah.
was fast. I really thought, because it was 20 something slides. So I thought there was no way we're gonna get through this. I was
Well,
already preparing, how do I cut and edit my section so you can.
No, because I was thinking it would have taken longer if we would have actually made commentary us on the other people's slide, but since we did it, and I thought it's not necessary, okay? And then we did it at the very end, and so hopefully they were taking some notes, maybe something we can think about. You might want to take some notes. One is you guys were welcoming you to chat at any time, but take some notes because we're going to end with questions for us about anything. And so maybe you can bring that up, because also if they ask questions right there, it's like, well, we're actually going to deal with it like we did, right? We're going to deal with that a little deeper, you know, on a few slides later by the next person taking charge. So, yeah, I was actually surprised that we went this far. I'm like, yeah, because I looked at the clock, like, yeah, Yvette, we're done. Or not. So,
Yeah. That's good. No, that's really good. I really like all those examples, and they're very pertinent, I think, to the communities that we work with specifically. So I hope that gave them more insight.
Yeah. I was also thinking how I was reading. I have a couple of new to me interventions in regards to like reducing anxiety. I ran across this book at Walmart a couple of days ago, and it's called the Mindfulness Notebook. And I thumbed through it and I was like, oh, I could use some of this. And I was like, oh, these are really good for like our staff, like learning, then they don't have a lot of things under their belt. And one that I came across, and I was going to share it right now, and then I just spaced at the end and I was like, okay, bye. but I'm like, damn, that would have been, it's called color breathing. Does anybody know that? Color
Yeah, yeah.
breathing?
good
Okay,
one.
new to me. So I'm like, yeah, so maybe we can have like 1 or 2 interventions to give to them continuously through these trainings, so that they walk away with that as well, for like dealing with like Charles was saying, like balancing between grounding and this and that. Like a lot of other staff might be like, oh, I've never done a grounding technique, or I don't do like a lot of psycho ed. I know some of my staff really want to help parents, but then end up saying like, what do I know? Like, how do I help? I don't know what to say. And that has led me to believe the lack of collateral sessions has to deal with the anxiety they feel, that they're like, parents are going to ask me like how to help their kid. And I'm like, I don't know if I have an answer.
Yeah.
I can barely do it myself.
So maybe,
Barely raised myself.
so maybe for the next training, we have like a slide or 2 on interventions and how do we provide psychoeducation about trauma to maybe parents
Yeah.
Right. Because you know what, since the next section is on intervention and support or something like that, it's called, right? So that would be,
Yeah,
that would
that's
fit
it.
in perfectly.
And that's why we're doing that next.
Next.
One of the words, because I'm not used to using this word, instead of trauma, say trastornos. Okay.
That's
To me, it's like,
Yeah.
but I really don't know how many persons really even use that word. Okay, is this a more, you had to have gone to, I don't know, high school in Mexico, prepa?
Yeah.
No, it's like, who uses trastorno? But then again, or am I thinking a lot of people know that, but I just didn't grow up with it, because they don't say trauma, they say trastornos,
But that's the word they use in the majority of the novelas.
Oh, okay. So so it's common.
Yeah. I watch novelas just for the research purpose of all of it.
Right.
We need to know what's going on with our culture. Okay.
You do.
So yes. And that's what males do. Lo veo por mi esposa. But they're the ones reminding her, "Ay, vieja."
Right.
It's like, you can't miss it. It's like, you
Right.
like it, man. You're sucked into it, dude.
Exactly.
It's easy to get sucked into them. So easy.
If
My
they're doing
Rich
well.
the other day told me, he's like, "Are you watching a novela?" I'm like, "No, it's on Netflix. It's just a show." It's like, it looks like a novela. I'm like, "It's a show."
It's a
Damn.
series. It's a
And
docu-series.
Yeah, it's a
Docu-series.
Netflix mini-series,
It's
Uh,
not a novela.
I walk
Not
in
a-
the house and they're watching, in essence, a novela, but it's just in Arabic. It's hilarious. And they're both like on it and they have their shows.
Love it. Love.
Nice.
Actually, Korean ones are actually pretty good. They're very like Latino ones.
I watched it just because I was really curious. I was scrolling through channels one time and I got stuck on it. I had no clue what they were saying, but it seemed really interesting. Like they were just talking. I'm like, this is exactly, you're right, Doctor. It's like a novela. And that's what I stayed there for until it went on commercial, but really interesting.
Yeah.
Mhm.
Sorry, Tom. Yeah, so I think it's good. And I think there's enough DSM and all that in there, which is very educational and all that. But I think what us being able to do our examples of what we learned, you want to.
Oh yeah, real quick. Hey guys, great job on the training tonight. Just popping in real quick. Hey, I was looking through the contracts and we're missing some for some of the students. I think we've gone over this in a meeting before, but just real quick, I don't have any on like Charles, Dominique, or what's his name? Matt.
Okay.
Yeah, but
It's on my group.
I think so. Not to point anybody out, but
I
was
think
like-
Marilyn's too, and I actually got it today because I've been asking her for it.
yeah.
I thought I had it at one point, and I was trying to pin her down on the last day, and she's like, I don't know, it's on the contract. And I'm like, I don't have it. She's like, I sent it to you, and I'm like, I've searched and searched and searched, and it's not there.